I would like to welcome all of you to the first Health Outcomes Seminar Series of the fall 2017. Today, it's a true pleasure to introduce Dr. Glen Schumock, Dr. JoAnn Stubbings, and Dr. Ed Lee. Many of you know Dr. Schumock is professor and head of the Department of Pharmacy Systems Outcomes and Policy. He will introduce in more detail Drs. Lee and Stubbings. Their topic today will focus on national trends in prescription drug expenditures and projections for 2017. Many of you might be aware of this work. This is part of a national series, basically updates, yearly updates on this topic that has been published in American Journal of Health System Pharmacists, has been funded by American Society of Health System Pharmacists and Quintiles IMS. So Dr. Schumock will tell us a little bit more about his co-presenters, a little bit more about the work, and I think he wants to do a sound check first, as Dr. Lee will be calling it.
Yeah, thanks.
Okay, thank you.
Just checking whether Ed can hear us. Ed Lee is a professor at the University of New England, and he's got a group of people in New England who are also going to be watching or listening to the program today. So Ed, can you hear us okay?
Yeah, we can hear you okay. Can you hear me?
Yeah, you sound good.
Great.
All right. Thanks everybody for coming today. I think we have a good program for you. Excellent speakers, excluding myself. I'm really just here to moderate. I want to introduce the other speakers and tell you a little bit of background about the project, and then I'm going to turn it over to them and have them present the bulk of the work, and then I'll come back at the end and tell you a little bit about some of the limitations and so forth. So you all know me. Edith's already introduced me. Ed Lee, I just mentioned, is a professor in the Department of Pharmacy Practice at the University of New England. He's well known in the pharmacy profession, does a lot of speaking. His areas of expertise are cancer, pharmacotherapy, and also expenditures, drug expenditures, particularly in cancer drugs. And then JoAnn Stubbings, sitting in the front here, many of you also know, is assistant director of the specialty pharmacy across the street. It's run by the college and hospital, and she's also a member of the faculty of the Department of Pharmacy Systems, Outcomes, and Policy, and also pharmacy practice. So let me just do a couple other things, some disclosures. Both Ed and I have a number of companies that we work with. We probably are talking about some of these drugs, so just know that. I don't think that influences anything that we're saying, though. I do want to acknowledge the American Society of Health System Pharmacists. You'll notice that these slides are actually theirs and from a webinar that the three of us gave a few weeks back, but they have a group called the Section of Pharmacy Practice Managers that supports the research that we do for this paper, and this paper then is published in the American Journal of Health System Pharmacy every year. I also want to acknowledge Quintiles IMS. This is a company that manages data, or at least the IMS part of it, and we've been using data from IMS for this. And I'll talk a little bit more about the methods in a second. And also some of the people from Quintiles IMS help with the data analysis. And the group of people who do this work is more than just JoAnn, Ed, and I. It includes Shelley Wiest from the University of Cincinnati. She's the director of pharmacy there. Katie Suda, who's in the audience. Where's Katie? She's also our photographer today. Katie has an appointment at the Department of Veterans Affairs out at Hines, and then also is on our faculty here. Then we have a couple people from Quintiles, Linda Matuziak and Bob Hunkler, who's a good friend of many of us. And then finally, Lee Vermeulen from the University of Kentucky, formerly from University of Wisconsin. Lee is the more senior author on this paper in terms of how long he's been involved. This is just the outline of what we're going to talk about, the introduction and methods. I'm just going to spend a couple more minutes on, and then I'm going to turn over to Ed, who's going to review basically our results in terms of historical findings and growth in drug expenditures in 2016. And then we're going to move to JoAnn, who's going to talk about drivers of future growth in drug expenditures, and also present our forecast for 2017. We basically use this historical data to try to predict what will happen in the next year, and we do this early in 2017, and the data is actually available earlier in the year, in case you're wondering, because now 2017 is getting close to being over. Like I said, I'll come back at the end with some limitations and conclusions. Okay, so just a little bit of background. This, as Ida said, is an ongoing series that's been published in ASHP going back to 1992. I think several of us have been involved in it for quite some time, not since 1992 though. And for the last 5 years or so, I've been leading it. The paper is, again, it's published typically as early in the year as we can, and it's used by hospital pharmacists across the country to do their budgets for the next year. So you may or may not know, I know some of the people that work in the hospital or the clinics, every year, a hospital pharmacy or clinic or wherever you work, the administrators ask you to develop a budget for the next year. So you have to try to forecast how much you're going to spend on drugs in that next year. And you do that by looking at your internal trends and what you know about the physicians and what drugs they're going to prescribe, what you know about new drugs coming to the market and so forth. And what we try to provide is a national overview of that to help out those managers as they make those decisions. So we do our own forecast that they use then and apply to their own local situation to try to create their own budget. So again, this paper was published just, I think it was August 1st issue of AJHP. There's also a lot of supplementary material that was published, a lengthy background on methods, as well as some additional results that are not shown in the paper. There's also something that ASHP does that's called infographics, which is an interactive web tool that you can use to look at the data. And so we're going to demonstrate that for you. Any questions? So just a little more introduction. As you know, I'm sure healthcare spending in the U.S. continues to go up. The most recent data that's usually published by CMS is from 2015. Healthcare expenditures overall increased by almost 6% to $3.2 trillion, 17.8% of our GDP. This is slightly higher than in previous years. It has to do with the strengthening of our economy. That the economy has a lot to do with what we spend on healthcare. And also, adding to this, I guess, is some uncertainty about what will happen with healthcare reform. In 2015, of course, we were still implementing Obamacare. There was a lot of expansion of people who are covered by insurance, which adds costs, at least initially, but down the road may save money. But now, of course, it's not really clear where that's going. Pharmaceuticals have also been increasing in the last few years significantly and historically, but there was a period of time that I'll show you where we had a slower growth than we had in the past. This is driven largely by new and expensive specialty medications that JoAnn's going to talk a lot about, and also price increases of older medications. So there's been a lot in the press about price increases of older medications, generic products, and we'll also talk a bit about that. And I already talked a little bit about what the purpose of the paper itself is. We do have sprinkled within here some audience participation questions. So our first one is, the Trump administration has tweeted that it may issue an executive order to address prescription drug prices. Which of the following might be included in that? Value-based pricing? Are you? Oh,
I wasn't aware. Do I have to wait for the whole question?
Oh, no. What is your answer? Go ahead. You're so eager.
I'm on a limb and say C.
C, faster approval of generics. Good answer. Anyone else? Who wants to raise their hand for the first one? Value-based pricing? Wow. Ed, anyone there? 340B change.
Yeah, we have people here, but nobody's volunteered their answers so far.
It seems contagious. 340B program? One. How about changes to how generics and brands are classified? Nice. You're all correct. All of these answers are correct. These are all things that the administration and others have talked about. Value-based pricing, where drug companies in particular will basically charge payers more based on the outcomes for the patient. So if a certain number of patients are cured, then the insurance company pays, and you don't have to pay for the drug if you don't get cured or whatever. Those kinds of programs have been talked about. Changes in 340B are always in the news and likely to occur. 340B is the program that allows pharmacies, hospitals to purchase drugs at a discount for patients who can't afford or who are in difficult circumstances. So, and it's a program where a lot of hospitals have saved money. Faster approval of generics when there's limited competition. This has been in the news quite a bit, and also changes in how generics and brands are classified is also something that's been discussed. So just a little bit on the methods. There's a lengthy report of this that is much more comprehensive, but we basically examine trends for the previous year and historical trends. We use this IMS National Sales Perspective database. It's basically purchases at the wholesaler level. So pharmacies, whether you're in a hospital, a clinic, or retail pharmacy, typically you buy medications through the wholesaler. So the wholesaler has records on every drug that's purchased by pharmacies and how much was paid, and that's the information that we get from them. So then we can report back by sector or channel or the type of pharmacy that purchased the drug. And then we also have information on factors that drive growth in spending, which includes the percent of expenditures that come from new products that weren't on the market in the previous year, the percent of the total expenditures that are basically increase in prices over the previous year for the same medications, and then the percent of expenditures that come more because of increased volume compared to the previous year. We can also look at brand versus generic and injectable and non-injectable. We focus on hospitals and clinics because that's the audience that ASHP, the funder of this, is interested in. And we also look at top drugs by expenditure across different categories, and also drugs that have the greatest increase in spending in the past year compared to the previous one. And then we also look at things that we think will happen in the future in next year. So drug and biologic approvals either in the previous year or expected in the next year that would impact expenditures within hospitals and clinics, drugs that go off patent are available generically, and that's going to decrease spending, hopefully, and how much that might impact spending. And then we'll pick areas that we think are particularly important, such as the use of antimicrobials, biosimilars, immuno-oncology agents, and those are the ones that we looked at in this particular paper, but that may change from year to year. From all of that, we try to estimate the future expenditures in the next year, and that's through kind of a combination of quantitative extrapolation of these trends, as well as more expert opinion, our own assessment of how those market factors might impact spending. And then we also look at projections from other groups to see how far off we are or on compared to what other people have predicted. And just to be clear, there aren't other groups that are predicting hospital and clinic drug expenditures, but there are groups that predict retail spending of drugs and also managed care drug spending. Okay, so let me turn it over now to Ed Lee, who's going to go through the historical trends, basically what we found for 2016.
Great, thank you, Glenn. Can you still hear me okay?
Yeah, sound good.
Great, thank you, and thanks for having me and letting me have the opportunity to present with you. I always like presenting with the UIC folks, and I've seen your campus. It's really beautiful, and wish I was there, but it's a beautiful day here in Maine, so maybe not. So I'm going to go over historical trends, starting with the all big picture in terms of the percentage increase in expenditures from 2016 compared to 2015. And if you look at the total spending, this was 5.8% growth from, again, the previous year. We'd actually predicted last year that there would be an 11 to 13% growth. So this was a lot lower than what we had expected, but it's still, again, growth in expenditures. And when you look at the different sectors, the top 4 sectors, retail, pharmacy, mail order clinics, and non-federal hospitals, they all had some growth. Hospitals are not growing quite as fast as the other sectors. Clinics are growing incredibly fast, and we'll talk about some of the factors that cause the incredibly fast growth in the clinics. There's still some robust growth in the specialty market with mail order pharmacies, and the retail setting looks like there's some strong growth as well. So the factors really that drive the growth in expenditures all really has to do with increased prices of existing drugs. So this is that price inflation that accounted for 5.4% of that total growth. Spending on new drugs, so these are new drugs that hit the market that accounted for 2.2% growth, but what's actually caused kind of a lower growth, I guess, is the utilization of existing drugs. So that actually shrank by 1.7%. So we're using some of the drugs that were on the market a little bit less, which accounted for a little bit of a shrinking of the expenditures. But again, that was outpaced by the increased prices and the spending on the new drugs. So these factors differ by the sector. So if you look at specifically hospitals and clinics, clinics on the left-hand side there, again, like we talked about how the total percentage growth was 11.9%, and most of that is due to the utilization of existing drugs, that volume and mix here. 8.1% of that was due to the utilization. And again, when we get into the more detailed figures about the specific drugs in the clinic, you'll see why exactly that is. So new products and price was about 2% of the growth, which is really, again, outpaced by the volume and mix there. When you look at the non-federal hospitals, again, there was a lot lower growth, that 3.3%. And most of it was due to actually price. Utilization of that volume and mix actually accounted for a shrinking of the expenditures. But again, that what really caused it to grow was that price and new products. Again, we can look at the total factors driving growth, but recognizing that this differs by sector. When we look at these trends now, so that was just last year, but when we look at the trends in drug spending, and this is a table of the annual percentage change in expenditures by year. You can see that the increase or the percentage change dropped a little bit in 2016 from 2015, but that's still pretty high growth in context of this whole landscape going back to 2000. You can see that in 2008, starting with the Great Recession, we had a much slower increase in drug spending. After that, the Great Recession resolved, and with the Affordable Care Act, it looks like the spending increased pretty dramatically, and we reached our high in 2015. So we'll talk about what this means for next year in terms of what our forecast is a lot later. So before I get into the actual drugs, we want to poll everybody to see what they thought was really the biggest reason for an increase in expenditures. If you could narrow it down to one therapeutic category or class of medications, what would that be? So within that top 25 drug list overall, in terms of the top 25 drug expenditures, which therapeutic class do you think saw the largest numerical increase in expenditures, not percentage increase, but numerical increase in expenditures from 2015 to 2016? And so we're going to use the super fancy digital polling system, which is the digits on your hand, right? Not digits on digital in terms of computer. But maybe, Glenn, you can tell me how people feel about this answer. Is it anti-infectives, anti-inflammatory agents, anti-neoplastics, or insulin products?
There was hands for all four, but I think maybe anti-neoplastics, just based on my visual count.
Okay, and we're saying D over here in this room.
Insulin.
And I think that's pretty consistent with the webinar polling when we did the webinar. And the answer actually is not C. You would think it's C because of the nature that I'm presenting it, but it's actually B, the anti-inflammatory agents, specifically the TNF inhibitors. So if we actually broke down the numbers, TNF inhibitors grew by $4 billion. Insulin was only $1.4 billion, and the anti-neoplastics was $2.2 billion. Anti-infectives actually went down. So now we'll go and talk about these, again, these specific drugs. And this is where I'm going to go and do the visualization here. So if you're following along with the manuscript, this is starting with table 3 here. And you can see that with the top expenditures overall, we have adalimumab, etanercept, infliximab. These are consistently at the top. Adalimumab is the #1 selling agent worldwide. And these have seen dramatic increases over the last few years. And a lot of that has to do with the impending competition that's coming to the marketplace with biosimilars. We have biosimilars approved for all 3 of these, but only one available for infliximab. And what's happening is that the companies are increasing their price because they're planning for that competition to eat into their profit margins. So unfortunately, we've seen a lot of price increases over the last year with that. The other reasons for the other kind of things to look at here, we have decreases in our hepatitis C drug. So this particular agent was a lot higher last year. In 2015, this was a 30% decrease. We also have generic approvals. So rosuvastatin, also we saw is right here. Had some decrease as well because of generics. So that was about a 21% decrease from the previous year. If we go and look specifically at the clinic channel, we see that infliximab is at the top, and it's been sitting here at the top since 2013, and it's actually seen a 5.5% growth from the year before. And so the question is, well, if there's a biosimilar out there, why hasn't it really moderated the growth of this particular agent? And the reason for that is because the biosimilar didn't launch until very, very late 2016. So actually, this is something that we're going to look at in 2017, is how did the biosimilar infliximab impact spending on infliximab products in general. The other reason why this clinic channel went up dramatically, actually the main reason why it went up dramatically, is because we had the PD-1 inhibitors, nivolumab, and also, where's my pembrolizumab over here. These 2 drugs accounted for a enormous growth. We're talking about 250% increase in nivolumab and a 105 increase in pembrolizumab. And they've basically, after about a year, they've entered the top 25, which is just incredible growth. And so I think that's really the majority of the reason why clinic expenditure growth is much, much higher than the overall. If we look at the hospital expenditures, again, we're looking at infliximab at the top. It doesn't really, it's not really, it's pretty clear that the biologics have been sitting at the top for a long, long time in the hospitals. The really interesting here is that you have this older drug, vasopressin, actually increasing by 109% due to a price surge with that, and we'll talk a little bit specifically about that in a little bit. We also noticed that filgrastim went down by 16%, and that's because of some competition in that space. And we'll talk. I'll give you some specific numbers around filgrastim in just a little bit as well. Okay, so if we look at the therapeutic drug categories, so this is table 6 in our manuscript, which is on this side here. Again, anti-neoplastic agents is the highest expenditure category within the hospitals. This accounts for 17.5% of the total hospital expenditures. And you can see that we spend a lot of money on these other therapeutic areas. Anti-infectives actually, even though it's at the top here, it's going down, went down by 8.1%, and we've seen about a 14% increase in these other areas like immunological agents and hospital solutions from the year before. Okay, so I've pretty much gone through these additional slides. So if you have the slides with you, I've talked about them in context with the infographic. So I'm going to skip ahead now to this slide, which is the myeloid growth factor slide that I talked about a little bit earlier. And this is something we wanted to look at because of competition in the myeloid growth factor space. Remember that TBO filgrastim was available a few years ago, but the biosimilar filgrastim was launched in late 2015. So we had some opportunity to look at about a little over a year's worth of data when we had 2 competitor products to filgrastim. And when you look at the trend in hospitals and clinics, you can see that the overall trend is a downward trend in total expenditures of the products. And when we ran it by, we looked at kind of per unit based off like an ASP calculation, it seemed like there was equivalent or more per unit use of these products. So it's not really that our utilization is decreasing, it's just that because of competition, the price is going down, and therefore our total expenditures is going down. In the hospitals, we actually see this kind of average decrease of about 800,000 per quarter, which is good. So, and you can see the uptake and the market share of the specific agents. Filgrastim still is the highest here, but the others are catching up. So it'll be interesting to replicate this type of analysis with infliximab and see how that works in 2016. When we look at specifically antimicrobials, I talked about how there's a decrease in antimicrobials. That was 2.3% across all sectors. Specifically, antibacterials was a 6.5% decrease, but antifungals actually went up by 4.5%. Most of it was, again, in the hospitals and pharmacies, mail order pharmacies or specialty pharmacies, approaching 10% decrease. The clinics had a little bit of higher use. And I think what's driving most of this decrease is the decrease in expenditures of the hepatitis C antivirals. You can see the decrease in from 2015 in terms of the percentage and the total numbers on the slide here. And I think a lot of that has to do with the decreased utilization because there are patients who are now getting their disease pretty much treated and don't have to go back on this. But what's still concerning is that you have a significant portion of the population who still does need to be treated by this, treated with hepatitis C drugs. So specifically, the agent that was the highest expenditure agent is decreasing, and a lot of that has to do with competition of new agents that are emerging. So you don't want me to try to pronounce these drugs. I know the feeling now. With people having problems pronouncing my drugs in oncology, I feel the same way with hepatitis C drugs. All right. Also, the last thing I want to talk about is the significant growth in older agents. And unfortunately, the Martin Shkreli drug, pyrimethamine, saw the highest percentage change, 552% increase from 2016. But overall, the total expenditure is not really that high in the grand scheme of things. But again, vasopressin saw a huge growth as well, over 100% growth in expenditures. And you look at the list of these older drugs and how important they are and how you would think that they shouldn't have these huge price hikes, but in fact they are. And there's a lot of issues with that nowadays with these kind of moving towards single source generics. So I'm not going to present the supplemental data, but just to let everybody know that we have supplemental tables with anti-neoplastics specifically in clinics in the top 20 anti-neoplastics in clinics, but also looking at the trends in the immuno-oncology agents and expenditures. So specifically nivolumab, ipilimumab, pembrolizumab and the regulatory events that basically preceded its increase in expenditures. So you can take a look at those figures in the supplemental part of the manuscript. So with that, I'm going to turn it over back to JoAnn, who's going to talk about the forecast and the future growth.
Or 115. Is this a microphone? Oh, it's a light. Okay. That is a microphone. Is it working? Okay. Okay. Great. Okay. Okay, so I'm going to talk about historical trends that's already been covered, new drug approvals so far this year, patent expirations, and marketplace trends. And I'll conclude with the forecast that we project. So polling question for you, which market trend, in your opinion, is most likely to impact health system pharmaceutical expenditures in the future? How many would say greater number of new drug approvals? Okay, aging of the population. Okay, legislation on pharmaceutical prices. Okay, and access restrictions for specialty drugs. Okay, so a few people answered yes to those, and all of these things will have some impact on health system pharmaceutical expenditures. So I'd like to start out with just a review of potential of drug approvals in 2017. And these are tables from the manuscript, so they're probably really hard for anybody past me to read. So I'll just summarize. I took the tables and then I put red dots by the drugs that actually did get approved. And this first table is first and second quarter of 2017. All of those drugs have been approved with the exception of baricitinib. And that drug was not approved. It received a complete response letter, which is a letter from the FDA telling the company that their drug was not approved. And this is from Eli Lilly. And that drug is for rheumatoid arthritis, moderate to severe. And they are in the process of getting ready to resubmit that for approval. I just wanted to point out a few drugs that have potential for over $1 billion in sales. So many of these drugs, or most of the drugs that are approved, are considered in the specialty categories. So you have dupilumab, which is Dupixent, which has a market potential of $1.3 billion. The third one is ocrelizumab, or Ocrevus, and this is an infusion for relapsing and primary progressive multiple sclerosis, and that has a market potential of $3.7 billion. We're starting to use a fair amount of this in the clinic. It is an infusion, and we project more utilization of it. FDA is on track this year to have one of their record years for new drug approvals. And so far in the first 6 months of this year, they approved 23 new drug applications. And that was more than was approved in the full year the year before. So they're way ahead just in the first 6 months. And they project that by the end of this year, we'll probably have about 41 drugs approved. The approval rate is 92%. And 14 of the 23 drugs approved in the first 6 months, we received a priority review, which is a faster review, and another 10 out of the 23 drugs received breakthrough status. And there are a couple other drugs that are not on this list that were approved in the first 6 months that also have very high market potential. One is sarilumab, which is also for rheumatoid arthritis, and that has a market potential of $1.4 billion. And obeticholic acid, or Ocaliva, which has a market potential of over $2 billion. And this is a new category for non-alcoholic steatohepatitis, or NASH. And this is a form of chronic liver disease that is projected to potentially impact up to 17% of the population. So we'll be hearing more about that. These are potential approvals in the second and third quarter. And several of these have high market potential. First one, avelumab, has a market potential of $1.5 billion. Second one, durvalumab, just over $1 billion. Zejula, which is neratinib, has a market potential of $1.2 billion. And I'd like to point out two new drugs that were approved for hepatitis C, and glecaprevir and voxilaprevir. And the voxilaprevir is Vasevi, and that has a potential of $1.5 billion. But the interesting thing is this glecaprevir is, the brand name is Mavyret, and this was approved and launched at a very significant price reduction. So not only are we seeing less utilization of the hepatitis C drugs, but now we're starting to see a lot of price competition among the brand name drugs. So the drug Mavyret is pangenotypic. It's indicated for genotypes 1 through 6, pangenotypic without cirrhosis in naive patients, but it's also an 8-week duration. So typically Harvoni and the other drugs are 12-week duration. This one is 8 weeks, and the per month cost of Mavyret AWP is $15,840 versus the per month cost of Harvoni is $37,800. So not only are we going to see treatment duration coming down, but we're going to see prices coming down as well. And so these are the potential approvals for the rest of the year. There's not as many approvals remaining as there were in the first half of the year, but we had one that guselkumab, Tremfya, received a priority voucher, so that was approved in July. And also the amphetamine extended release was just approved in September. So that's what we have for new drug approvals. This is a list from the manuscript of the patent expirations that were projected. And again, the red dots indicates drugs that did receive ANDA approval from the FDA. And the FDA is going gangbusters with approving ANDAs because they're trying to really speed up generic competition and approval of generic drugs so that that could potentially alleviate the prices in the marketplace. And so in June of this year, they approved 88 applications just in 1 month. And they're on pace to approve about 760 ANDAs for the full year. But however, this is dwarfed by the number of submissions they've gotten. And so in order for FDA to keep up with all the submissions they have, they need to be approving about 100 ANDAs a month. So they're not quite keeping up yet. They are trying to streamline the reviews in an effort to increase price or create more price competition. And FDA did publish a list of 267 brand name drugs that are off patent but currently don't have any generic competition. And they're trying to encourage companies to come up with generic competition. So I'd like to move on to key marketplace trends, and that would be changes in the economy, the population, and the healthcare system, 340B program changes, drug pricing, price increases and price controls, and then talk about specialty drugs and biosimilars. And this is a chart that most of you have probably already seen. And we always talk about aging of the population, but it's very important because the population is aging significantly. In 1900, the percent of people in this country who were 65 and over was 4.1%. And so the left side of the scale is or the blue bars are the number of people, and the orange line is the number of people 65 and over as a percent of the total population. So in the year 1900, that was 4.1%. By 2010, it increased to 13%, and by 2030, it's projected to increase to 20.9%. So what that means is that by 2030, the entire country is pretty much going to look like Florida. So right now, the population in Florida over 65 and over is 21%. So by 2030, we'll be at 21%. Currently, we're at about 15%, but it's going, and who knows what Florida will look like by that time. So then moving on to the economic and political climate, the healthcare system changes could impact insurance coverage for key groups. I'm not going to even venture to give any projections about what's going to happen with healthcare reform, but there is a lot of concern about the potential impact on key or vulnerable groups, such as children, maternity, rural areas, Medicaid expansion, and at-risk populations. However, we are seeing a lot of activity at the state level, and there is a belief that the true healthcare reform is going to happen more extensively at the state level before it even happens at the federal level. For example, California has a bill called Healthy California, and that is a single-payer health plan. New York has a proposal for single-payer, and Nevada has a proposal that they call Sprinkle Care, which is named after their legislator, whose name is Sprinkle, and it is a commercial plan based on Medicaid. So there's a lot of activity going on at the state level. And then moving on to the 340B program, all I can say in one word about 340B is that it's tumultuous. And the 340B program has had a lot of challenges. There's nothing specifically changing right now, but there's potentially a lot of change that's going to happen. This year, in June 1st, the leaders of the House Energy and Commerce Committee sent a letter to HRSA, which is the agency that oversees the 340B program, and in that letter they expressed a lot of concerns with the 340B program. And then that was followed up on July 18th with a hearing with HRSA to talk about oversight of the 340B program. In the meantime, there was a draft legislation and executive order that was circulated but not acted on. And then on the following month, there was a letter sent to 28 House and Senate lawmakers defending the 340B program. But then as a follow-up, on September 8th, there was a letter sent by the Energy and Commerce Committee to 19 different health systems that made extensive requests for information on how they're using the 340B program. For example, they asked for 340B data on all of their different drug categories. They asked for dispensing information. They asked for how they calculate and use their program savings. They asked for policies on how they help uninsured people, and also if they're using contract pharmacies. And the interesting thing about this letter is that it was sent to some very significant safety net hospitals, but it was also sent to some very large hospitals that are 340B institutions, but may be using it, may not be serving completely underserved populations. So the 340B program has a lot of controversy ahead. And moving on to drug pricing, legislative attempts to address drug pricing have been made, but the potential impact is debatable. And so the FDA Reauthorization Act, or FDARA, was passed by the House on July 12th, and it does make some policy changes that address drug prices. However, these policy changes are largely symbolic. For example, there was a provision that requests the Health and Human Services Secretary to commit to work with Congress to lower the cost of prescription drugs. So that's symbolic. A priority review pathway was set up for products that have less than 3 approved generics. And also there is granting of additional marketing exclusivity for generics that are designated to be competitive generic therapies. A separate hearing on drug pricing was planned by the Senate Committee on Health, Education, Labor, and Pensions, but it was postponed. And there were supposed to be 3 hearings this year on drug pricing. The first hearing took place in June, and what happened with that hearing was that was the middle of healthcare reform. So instead of talking about drug pricing, they spend most of the time talking about healthcare reform. So the second hearing that was planned for July was postponed, and now there's supposed to be a third hearing in the fall that's supposed to be based on a report on drug pricing from the National Academy of Sciences, and I have not seen any date or announcement for that hearing yet. So it seems like things may be a little stalled out. And similar to what I said about healthcare reform is that the action could be at the state level. And so Maryland just passed a law that's going into effect on October 1st called their anti-price gouging law. And that requires the Attorney General, or it authorizes the Attorney General to prosecute firms that raise their prices too much. And this is in the generic area, so it gives them power to do that. Also, California just passed a drug price transparency bill that requires manufacturers to notify California 60 days before they have any big price increases. And this was really hotly opposed by pharmaceutical companies, but it's still passed. And so moving on then to specialty drugs. And the reason we talk about specialty drugs is that most of the drug approvals were specialty drugs for this year and previous years. And also they potentially impact health system expenditures because health systems dispense a lot of specialty drugs, but on the other hand, a lot of manufacturers and payers place restrictions on specialty drugs. So even though a health system might be attempting to prescribe it for their patients, they might not be able to dispense it because it's been restricted. So this chart shows the different forms of restrictions that can be implemented by manufacturers. And this has an impact on health systems because it can impact their access to drugs or their 340B price or their cost of goods discount, which is a wholesaler discount. If the drug has open access, then the health systems have access to the drug and all the prices. If they restrict the drug to specialty wholesalers, for example, McKesson Specialty, then the health system has access to the drug and the 340B price, but not the cost of goods discount, which has a big impact on their savings. If it's limited distribution, that means that there's only certain specialty pharmacies that can dispense. Then the health systems has no access to the drug. And if it's exclusive, that means there's generally only one specialty pharmacy and health system has no chance of getting access to it. There's another thing that's starting to happen that's a huge concern in the health systems, and that is the payer restrictions. And this is an example of a website from a payer that is starting to restrict infusions. So infusions are always given in an infusion center, either at a hospital, outpatient clinic, or a private infusion center. And payers are starting to attempt to restrict infusions the same way they restrict the take-home prescriptions. So this means that, for example, this payer, this health plan has a list of drugs where they say, now, UI Health are used to administering Ocrevus or Lemtrada here at your infusion center, but now we're going to require prior authorization, and we may require that infusion to be given at a separate private clinic or home infusion. So we would not be able to administer it to our patients, and we would not be able to have that expenditure. So that's happening at to a greater extent now. It's something we're seeing in the future. Biosimilars will potentially further moderate the growth of expenditures in the specialty drug category. Biosimilars are very hard to get approved. The first cycle approval rate is about 40%. And there is some action with the drugs that are listed here. But there's a lot of patent issues with biosimilars, so none of these drugs that are either recently approved or getting approved are anywhere close to being on the market. So I'd like to conclude with how we got to our forecast. So we're forecasting for 2017 still growth, but a little lower growth than we had the previous year. Hospitals 3 to 5%, clinics 11 to 13%, and overall 6 to 8%. So I'll turn it back to Glenn.
I know we have another class in here. I think they know that we're going to be a little bit longer today, but if you guys want to start picking up or anything, that's fine. I'll just wrap up real quick. These are some of the limitations of the work that we do. We have tried to assess how accurate our forecast is. In fact, Todd was asking me earlier if we've done that. And you can see at the bottom here, we have a paper that we published that looked back in time and looked at how accurate our forecast was compared to what actually happened in the next year. Actually, it's not too bad. That we've compared ourselves to CMS, who does this forecast of retail drug spending. And if you look at this line, this is absolute mean error. It's a number of percentage points that we were basically off of what actually happened. So we're about 2 percentage points for hospitals and 4.7 for clinics, whereas the CMS forecast is about 2.2 percentage points off on an average over time. Now, if you don't like our forecast, there's other ways to predict drug spending. One thing I recommend hospital pharmacies do is buy a rooster, and you can do that. There's, of course, watching Game of Thrones is always good. This is my favorite here, Rumpology, predicting future drug spending. So if you think we do a bad job, go ahead, have at it. So JoAnn said what our predictions were for this next year. As Ed mentioned earlier, last year we predicted a little bit high, but still the information that we're presenting is not so much the forecast, but all of the data that JoAnn and Ed presented that helps hospital pharmacy directors make their decisions about their budgets for the next year.